With that, we'll open it up. Given the number of people standing in queue, I'm going to ask that you try to narrow your comments to 1 minute. If someone before you makes your point, feel free to say you agree with the previous speaker. Thank you, and we'll begin with our first witness. 1 minute, please.
Tam Ma with Health Access California. Ditto the statement that the chairwoman just read, and we also want to note that there are 3 million Californians who are in fee-for-service Medi-Cal today who need access to care, and we believe that increasing the rates and rescinding the cuts will ensure that they have access to the doctors that they need. Thank you.
Next witness.
Good afternoon, Madam Chair and Senator Monning. I'm here to talk about access to care for individuals with autism who are now receiving behavioral health treatment through Medi-Cal. I am the president of the Southern California Consortium for Behavior Analysis, which is a group of 38 companies serving thousands of individuals with autism across California. And we're very concerned because right now DHCS is currently setting rates for our services. And we're worried that if the rates are not sustainable, that it will affect access to care and also quality of care, because it may not be possible to provide sufficient training and oversight of the direct care staff. And so what we're asking is that as DHCS is setting the rates, that they look at the regional center rates that we negotiated with the regional center, because those clients are going to be transferring over into Medi-Cal, and that they use at least those negotiated rates prior to 2008, not look at the median rates, and also to take into consideration the fact that the Lanterman Coalition is calling for a 10% rate increase to the regional center provider rates, and that if DHCS is now going to be taking over this service, that they should also be looking at incorporating that 10% rate increase to the Medi-Cal rates for individuals with autism. Thank you.
Thank you. Next witness.
Hi, my name's Yu Lee. I'm also a member of the Southern California Consortium Behavior Analysts. I was previously a beneficiary of Medi-Cal as well when I came to the United States. And I'm currently the founder of CARE, which is an organization that provides autism-related services to individuals with developmental disabilities. So I echo and ditto the sentiment of my colleague that it's very important that we actually proactively look at providing sustainable rates that would sustain our system, because we heard the sentiments about the dental system. So we want to be very proactive and have those active conversations with stakeholders to make sure that we set up an infrastructure and a system that will be successful to service the clients that are definitely very low income, that are needing the behavior and autism services. Thank you.
Thank you very much. Next witness, 1 minute, please.
Thank you, Madam Chair. I'm Bill Barnaby here on behalf of DaVita, the largest dialysis provider in the country and in the state. The lack of funding is going to be crucial to keeping pace with the increasing incidence of end-stage renal disease, which is fatal unless they receive dialysis treatment to keep them alive and or to await a transplant. There will not be any new facilities built if there's not the money there to do it. And so we're looking at a ticking time bomb of a lot of potential deaths, because if we don't build new facilities, the incidence is going to continue, and there's only one outcome for people who need dialysis and can't get it, and that's death. The same patients also need non-emergency medical transportation, which is different than the medical transportation the department is providing through managed care. These are people who have functional limitations, had received TARS approved by the state, and then once they were transferred forcibly into managed care, they lost their entitlement to the patient safety features of non-emergency medical transportation. So those things need to be done. And really, the question is the political will, to recognize that poor reimbursement levels across the board are hurting patients, and we're looking at a very difficult future unless something is done. And it's not just numbers, it's political will and recognition of a problem to do it. Thank you very much.
Thank you, Mr. Barnaby. Next witness, please. 1 minute.
Thank you, Madam Chair. Eduardo Martinez with the California Medical Association. Just to be brief, definitely agree with the statement that you read. Also, definitely want to support sort of the general sentiment of the LAO and really trying to focus what we should be doing to ensure access to care is sort of maintained. Really want to emphasize that, just the requirement that rates be actuarially sound, we don't think is adequate to ensure that access is being delivered and that standards are being met. The federal government recently came out, the Health and Human Services Office of Inspector General, they took a look at Medicaid managed care networks across the country and found over half of the providers listed in some of these networks were not didn't exist, or bad numbers, or weren't practicing medicine anymore. We've done our own surveys of a California Health and Wellness in Butte and Imperial. Similar findings there. The LAO mentioned that the JLAC is going to come back with, again, another sort of secret shopper type survey to really determine, is that access really being delivered? You also can look at the HEDIS report card measures, which, but the same plan has a commercial, Medicare, Medi-Cal plan. You can see the quality and access ratings go down as the product type varies. So really encourage you to take a strong look at some of those different ways of measuring access. Thank you.
Thank you. Appreciate it. Next witness, please.
Madam Chair and members, Barbara Glazer on behalf of the California Hospital Association. Ditto to the remarks you read. Thank you. And I want to report that a number of our hospitals are seeing an increase of Medi-Cal enrollees in their emergency room. Some hospitals are reporting seeing 50 to 60% more Medi-Cal enrollees than other enrollees. So they might be seeing a 5 to 6% increase overall, but in Medi-Cal enrollees, it's 50 to 60%. And we think this is in large part due to the fact that these people can't get in to see a primary care physician because the kind of things they're coming in for could be dealt with in a physician's office or in a clinic. So there is a direct relationship between rates and getting access. We would urge the committee to consider eliminating all of the AB 97 cuts. Thank you.
Thank you. Next witness.
Matt Reese, CEO, Mayor's Memorial Hospital, a critical access hospital in the state of, up in the northeast part of the state, 75 miles east of Redding. I want to ditto Barb's comments as well as let you know that we're a critical access hospital. We have 22 beds. We're licensed for 99 skilled nursing facility beds. This last year, we had a fire up in our area, a forest fire. When that fire happened, we had to evacuate one of our facilities. We had 43 residents in that facility. We were not able to find homes for all of those patients within a 100-mile radius. In fact, we have 22 Alzheimer's beds. 5 of those patients could go to beds that were qualified for their services at the time we had to evacuate. We are a vital service up to in that part of the area. We cover an OB service area larger than the state of Massachusetts. If the AB 97 cuts, if the AB 97 clawback is implemented in June of this year, we're going to have to look at this and other vital services that we offer to this part of the state. If we go out of business, there's a 150-mile stretch of 299 that will not be covered with an emergency room, long-term care services, or other services that are vital to the community, including OB. OB is one of the things that we put on our agenda back in October to look at because we're having financial issues, and that more hospitals have closed in the last 2 years than have closed than closed in the previous 10 years.
Right.
And so we need to do away with this clawback to AB 97. We're going to put patients and people at risk if we do not do away with this clawback. Thank you.
Thank you very much. Next witness, please, 1 minute.
Yes, Dave Kiefer, UHW, ditto. I just want to point out that hospitals lose $4 billion a year treating Medi-Cal patients. They have one of 2 ways to make it up. They can go out of business, Daughters of Charity, Doctors Hospital, we know all that, or they can increase the cost to commercial payers. So an estimated $1.6 billion of that loss is passed on to commercial payers in the state of California. Currently, family coverage in this state averages about $17,000 a year. What we lose in Medi-Cal gets made up by pushing up and on the commercial side, and we end up with an affordability crisis. The last thing that this hidden tax does, though, it also means that we're financing our Medi-Cal system in a way that does not get us any federal match. If we directly funded those losses instead of making it come out of the commercial side, we could draw down federal money and double the money. Thank you very much.
Thank you. Next witness. 1 minute.
Hi, my name is Cheryl Laughlin, and I'm an owner-operator of 18 ICF DDHs and in facilities in LA and Orange County. In the state of California, there are over 1,100 facilities such as mine. We provide services for over 7,000 individuals, and we have over 15,000 employees between us. We're not only have been impacted by the cuts imposed by AB 97, but we have been in a rate freeze since 2008. We are now in an unsustainable position. I myself last month had to empty my savings, my son's college account savings, into my business to meet my payroll. Because we were not funded for the minimum wage pass-through from the month of July when it was implemented by the legislature until October the 20th when we were able to start billing, we as individual providers, which most of us are not large corporations from multi-states, we are individual people. That is not an acceptable way to do business in the state of California, and many of us are on the verge of going bankrupt because we're not adequately reimbursed. We have not received our rate increase from August of 2014, and these type of things need to be addressed by the Department of Healthcare Services in providing us timely reimbursement, adequate reimbursement, and I don't know anyone in this room who could live on the rate of what they made in their salary in 2008 and afford to live in California today, and yet you expect us to take care of the most vulnerable population in the state. Thank you.
Thank you very much. Appreciate it. Next witness, 1 minute.
Hi, my name is Gwendolyn Smith. I operated 4 ICF DDH facilities. I have closed in December. It was getting more difficult to forward the SPA monies to the regional center. I gave a 60-day notice. Of the $54 million of the SPA monies right now, there's $12 million that is outstanding, which is a delinquency rate of almost 25%. According to DDS, facilities that are not forwarding the SPA monies to the regional centers will not be getting the monies. Instead, DDS will forward the monies directly to the regional centers, and I believe that will jeopardize the federal monies that California receive. Also, the QA fees, which are delinquent, Medi-Cal has started reducing the payments by 5%. If the facilities do not continue to receive the SPA monies, which we're actually using to keep going, and then more facilities will be closing. I just happen to be one of the first ones. Thank you.
Thank you very much for coming today. Next witness.
Good afternoon, Gary McComber. I serve as Rates and Reimbursement Consultant to the Developmental Services Network. Prior to that, I served as State Director of Developmental Services for 8 years. So I'm used to being over there rather than here. When the program was created in the early 80s, it was designed as a community-based alternative to the large state developmental centers, both in terms of providing services closer to home and at less cost to the taxpayer. As pointed out, the facilities have been a terrific success. Prior to the Budget Act in 2009, DHS prepared, as it had for the prior 29 years, its annual rate study. Providers were pleased to see that the DHS study found that providers were due an increase of about 6% in one category and about 9% in the other. Instead of receiving that, the rates were frozen and rates were cut up to 10%. So in many cases, we've actually seen a 20% when you compare the DHCS own identification of need. As a condition of federal approval for the cuts, DHCS committed to do quarterly access studies starting January of 2013. They have not done one to date. Last fall, I'll leave that out in the interest of time, we'd ask that you amend Welfare and Institution Code to rescind the Trailer Bill Freeze Action from 2009 and the AB 97 cuts. Absent this action, we're bound to see more facility closures and placement of medically fragile people into inappropriate care settings. Thank you.
Thank you very much. Next witness.
Hi, my name is Ellen Fisher, and myself and my husband and my daughter operate 5 ICF DDHs in the Bay Area. We are the true definition of a mom and pop operation. We are very small. We do everything ourselves. I don't regret a minute of the work that I've chosen to do. But we operate under very, very difficult circumstances, and it's getting worse and worse. The cuts to the Medi-Cal system, we are all part of the same system. When there are reductions to physical therapists and occupational therapists and speech therapists and all those ancillary services that we need for our consumers, and the state requires that we provide them, we end up paying them. I spent 18 months trying to get a wheelchair for one of my consumers. Finally, I figured out how much it was costing in my salary, and I just wrote a check and paid for the wheelchair myself. It's just you can only fight so much. We continue to have serious access problems in dental and psychiatric services, and I support everything that everybody has said regarding the need for services for our population. And finally, I just want to say that I've done what I swore I would never do, which is essentially create a 2-tiered system in my organization. The consumers that get Medicare and Medi-Cal, they get great services. They don't have to go to the emergency room for primary care. But for those that are still in Medicare, Medi-Cal only, we are stuck, and they are not getting the same level of services that their roommates are getting. And it's a crazy system, and it really, really needs to be fixed. fixed. Finally, the last point I want to make is that we opened in 1986. A third of our consumers came from Sonoma Developmental Center and Stockton, and they're still with us. They're receiving the same services. They have received the same services for the past 30-some years, and our reimbursement rates, it's unconscionable that we are providing exactly the same services in a community setting that the developmental centers are funding, and our levels of reimbursement are astronomically different. So thank you for your time.
Thank you very much. Next witness.
I'm Nancy Fry. I'm also an ICF-DDN provider, and I am very concerned about the rate freeze and cuts. And here's my audited reports from 2008 to 2012. And sadly, my costs went up $112,827, but I am stuck at these frozen rates. And what's even more concerning is this year I have a shortfall of about $45,000. And so I have to make cuts. I have to cut staff. But basically, if I can't do this, then these people are going to lose their home. And I was one of the original ones studied in the 80s, and we were cost effective then. They were delighted at the cost savings versus the developmental centers, and that still holds true. The cost that's being provided to us is less than $80,000, and the cost in a developmental center is $500,000. So 6 of our people are living in a home to them. And some of them have lived there for more than 20 years, and 6 of them for the cost of less than 1 in a developmental center. We also contribute through our quality assurance fees, and more than $55 million from federal funds came in from the ICFs to help support this living. And we feel that some of this money should be used to provide and continue their care. And the reason that it's so important is that these people in my home have lived there so long that they've become like family, and this is their home, and it's at risk. And I mean, next year might be too late. So I ask that you please act and help them out. Thank you.
Thank you very much. Every witness is averaging about 1.5 minutes, so I'm going to give you kind of a high sign when you've got about 15 seconds to go, because I want to respect the rest of the people in the line, please. So 1 minute.
Thank you. Michelle Payne from RCCA Services. I manage 20 ICFs from Sacramento to San Jose, and I wanted to just bring to your attention that there are a lot of costs that are in the cost reports that are disallowed. One of those large costs for us is enteral or feeding supplies for individuals who need G-tubes. And for our homes, the average cost of those is about $1,600 for a home, and so those supplies are not reimbursable. Also, because we are reimbursed at the 65th percentile, there are lots of costs that are not captured and not reimbursable. Our rate, the maximum rate for 2 of our homes in San Jose is $220. But our costs are actually over $240 a day. And so our homes definitely are at risk, and we do great work in the community, and we have needed services, and they're at risk. And I want to personally invite all of you to visit our homes and see what we do every day and the impact that we make. So either in Sacramento or in the San Jose area. Thank you for your time.
Thank you. Appreciate that.
Hello, I'm Christy Foy here on behalf of the California Dialysis Council and the California Clinical Laboratory Association, and we are asking for elimination of the 10% cut for providers. Low reimbursement rates do lead to access problems. Without proper access to key services and testing, patients do get sicker. Not only is that a terrible outcome for the Medi-Cal patients, but it also ends up costing the state more money to treat these sicker patients in a hospital setting, as was stated earlier when they show up in the emergency room. So for all of these reasons, we strongly ask for repeal of AB 97. Thank you.
Thank you. Next witness.
Madam Chair, members, my name is Eamon Casey. I'm with a company called New Motion. We're a complex rehab technology provider. We provide mobility products like the ones you see being used behind me. We're a subset of durable medical equipment and supplies, and we're affected both proactively and retroactively by the 10% cuts. These cuts have affected our ability to deliver services in certain geographical areas. It's also denied access to certain items and services that in the past we were providing, and it actually threatens the very existence of complex rehab providers in the future. So we're asking that you restore the 10% cuts both retroactively and proactively. Thank you very much.
Thank you. Appreciate that. Next witness, please. 1 minute.
Of for Independent Living, the local Independent Living Center, and I'm here representing consumers who need durable medical equipment. These are our lifelines. We can't go to the grocery store. We can't do anything. So please restore the cut so we can get the services we need. Thank you.
Thank you very much for being here. Appreciate you.
My name is Helen O'Connell, and I'm also representing Resources for Independent Living. I recently had a situation where my chair was in repair for 3 months. I could not go to the doctor. I could not go to physical therapy. I had to hire somebody to get me to and from critical appointments at the emergency room. I strongly suggest that you repeal the cuts that were made, and I support the statement that was made at the beginning of the fight. Thank you.
Thank you very much. Appreciate it.
Thank you, Madam Chairman. I'm Alan Betancourt from Premier Medical. We are a 21-year Medi-Cal provider for custom rehab technology and equipment. Much like my industry colleague, Eamon Casey, we work with the most fragile individuals in terms of their equipment. I would just like to say that I could ditto what everybody has said here, including what you read at the beginning in terms of your statement. But for us, our industry is a little different. We're reimbursed not fee for service, but actually equipment we provide. The last round of cuts, we literally had to stop providing certain levels of equipment. My concern now is there's a retroactive cut. If there's a clawback, it will completely keep us from providing any level of equipment at all. Thank you.
Thank you. Appreciate that.
Thank you, Madam Chair. David Gonzalez on behalf of CAPG. Our providers are responsible for the care of some 20 million patients. We've been very supportive of the Medi-Cal expansion through the ACA, and our providers are committed to making the program work. However, we ditto the concerns expressed about the impact on this very vulnerable and important patient population. Thank you.
Thank you. Next witness.
Michelle Stoll-Parvensky, Children's Defense Fund, California, also here on behalf of the Children's Health Coverage Coalition, which includes Children's Partnership, Children Now, California Coverage and Health Initiatives, United Ways of California, and PICO California. We'll echo a lot of what has already been said. We think it's really essential now that we have half of California children in Medi-Cal that we ensure that those children are actually able to see a doctor or other provider when they need one, when they need care. And we think that increasing rates up to an adequate level is an important part of a comprehensive solution. And I also want to flag that we would recommend a comprehensive assessment of children-specific access to care in Medi-Cal. I think as we saw in the previous section on what happened when we did an audit of access to dental services, that can provide some really important information that can help us identify where the specific problems are and identify some solutions for ensuring that every child has the care they need. Thank you.
Thank you. Next witness, please. 1 minute.
Laurel Mildred, representing California's CBAS programs. We serve over 28,000 elders and people with dementia and severe disabilities who are poor and therefore at high risk of being forced to live in a nursing home against their wishes. CBAS costs about $9,000. An equivalent person in a nursing home care costs about $83,000. But the 10% rate cut is devastating our provider network. Since 2011, 53 of the state's CBAS centers have closed. Many more are right behind. Once they're gone, they're gone. This is a special model built for the Medi-Cal population. Many of the centers have 100% Medi-Cal. And it costs about $1 to $3 million to start a new center. So we're losing our permanent infrastructure to serve this population, and we urge the restoration of the cut.
Thank you. Next witness.
Jody Hicks, representing the California Academy of Family Physicians, and I just want to speak briefly, specifically to primary care. The family medicine specialist, these physicians are the only specialty that's 100% primary care. So for them, they recently lost the primary care rate bump that the ACA put in place, in addition to the AB 97 cuts that they're facing. So virtually overnight, they saw their rates go down by about 50%, which has a huge impact. And we know that the ACA put that rate increase in place because they believed that it would incentivize more participation. And early studies are showing that that is in fact true. And the 10 states they looked at, those states had better accessibility And across the board, the findings were as the rates increased, access also increased. So we know that that makes sense. And the Academy has put together for themselves a task force of physicians that primarily take Medi-Cal just to answer questions amongst themselves. And I was on a call with them, and I just want to say one, they all had a story to tell about access. One in particular was a child in the emergency room, broke their wrist, had to get a referral from a primary care because of managed care before they could see the specialist, took 3 weeks to get that, another month to get to the specialist. By the time all of that had occurred, it was, there was a deformity in the child's wrist that will be there forever, that didn't need to be there. And for oversight, we wholeheartedly agree with LAO's concerns. And if you're expecting, that mother did everything she was supposed to do. She got the primary care, she did everything. And if the next expectation is for her to call the department and then complain, we can do better than that insofar as oversight. And we agree with LAO and doing secret shopping and all the things we need to do as a state. Thank you.
Thank you. 1 minute, please.
Yeah, Madam Chair, Rick Rollins, representing the Association of Regional Center Agencies. We're here to support our great providers in the ICFDD world. We have 7,000 of our clients that are served by this group of providers who've dedicated their lives to helping those folks in the ICFDD. And also we want to express our concern about the rates for those children with autism who are going to be moved out of the regional center system based on the law requiring folks on Medi-Cal to be served through that program with autism. The rates are critical, and we absolutely don't want to see a two-tier system for those who have private insurance and regional center funded services and those who are on Medi-Cal. Thank you.
Thank you. Next witness.
Hello, Laura Parr on behalf of the 911 Ambulance Provider Medical Coalition, and we serve the largest population in some areas, and we are the sole providers as well in some counties. And like a lot of emergency providers, we pick up a patient regardless of their health care coverage or income. So we are in support of all the other comments that were made, and thank you.
Thank you.
Jennifer Snyder. On behalf of the Osteopathic Physicians and Surgeons of California, I'd like to echo the comments that from Jody Hicks with the California Family Physicians especially. Also here on behalf of the California Association of Health Facilities for their ICFDD providers, you heard some very eloquent testimony directly from those today. I just would like to reiterate that they are 100% Medi-Cal, so they cannot find other ways to cover their costs. So when they talk about their cost reports and costs, Medi-Cal's their only payer. And then National Coalition for Assistive Rehab Technology, you also heard from the custom wheelchair providers. That's their group that I work with. For them, they mentioned the retroactive cuts, but there are only few providers that are left on that short list of folks that will possibly receive a bill sometime in the next 3 to 4 months that will tell them that they owe the state a certain amount of money, and the state's going to start taking that out of their claims going forward. That's an additional average 5% cut, in addition to the 10% cut on a custom wheelchair that can be as much as $30,000, if not more. So it's significant for these folks. So we thank you for your time.
Thank you. Next witness.
Good afternoon, Brianna Pittman with Planned Parenthood. I would just say ditto to everything that's been said. And the one thing I would add is while I really appreciate the focus on monitoring access, I think when you hear patient stories, you realize that there is a real access crisis here, and it's only getting worse. We have a volunteer from Fresno named Samantha who recently got Medi-Cal, and as a daughter of farm workers was very excited to finally be able to access coverage, had a lot of difficulty actually getting coverage, called 5 different doctors, 3 couldn't see her, and 2 required a month wait. She had the flu, that wasn't gonna work. Recently became pregnant, she and her husband are expecting their first child, and is having similar difficulty getting her prenatal care. She's in her 2nd trimester, and still looking to get some of the ultrasounds and things that one would normally get in the 1st trimester. Took 6 weeks to schedule 1 ultrasound. It was 30 miles away. Her husband took the day off to drive her there, and it was canceled on the same day. So that was just a couple of weeks ago. She's still trying to get that rescheduled. So we would just urge this subcommittee and the legislature to look for funding in the budget. We know that we really do need to invest in these provider rates.
Thank you.
Thank you.
Hi, good afternoon, Senators. My name is Sylvia Castillo. I'm with California Family Health Council, also today representing the Bay Area and Sacramento Women in Healthcare Reform Coalitions. CFHC administers a Title X federally funded program for this state. We work with over 70 health centers that combined operate 340 health centers across 38 counties here in California that serve over 1 million men, women, and teens in this state. This issue with provider rates particularly impacts family planning health centers because at some centers, the fee-for-service Medi-Cal patient population can comprise up to 90% of their patient population. So this affects their bottom line to a certain extent. And I just wanted to remind you that before these rates were cut in 2011, the fee-for-service rates were established in the 1980s. So now in 2015, we're paying providers less than they were earning in the 1980s. I was born in the 1980s, FYI. Thank you very much.
Stop bragging. Okay. Thank you very much. Appreciate it. Next witness, please.
Hi, David Thompson with the Dental Surgery Centers again. We just want to say that we all agree with the stakeholder concerns that the rates are too low, and I want to say with absolute doubt that increased rates will increase access to care. There shouldn't be any question about it. We don't know why there's any resistance to that. It's a really odd question that we discussed for so long. But I do want to say from our perspective that each of the dental surgery centers in California have 300 to 400 referring offices that refer to them. And as soon as these rate decreases hit, a lot of those referring partners saying, sorry, we're not taking any more Denti-Cal patients. Don't refer them back to us after you treat them, things like that. So we do know that the access to care will go up. Thank you.
Thank you. Next witness, please. Final witness.
Madam Chair, Senator Monning, Tim Madden, representing the California chapter of the American College of Emergency Physicians. Ditto to all the comments they made, especially we can attest to the influx of Medi-Cal patients into our emergency departments who are very sick. They're sick because they can't get access to care. One quick question that was, or excuse me, one quick story that was highlighted in a recent news article of a patient who came into California Hospital, which is in downtown Los Angeles, 4 times in 5 weeks, late stage cancer, couldn't get access to an oncologist, couldn't get access to the chemotherapy that he needed. The emergency physician, along with the social worker, spent time each time he came in to reach out to their managed care plan to try and get him access to an oncologist with no luck. So once again, more stories are coming in like this showing the true need for what we're talking about. Thank you.
Thank you very much to the members of the public for your disciplined presentations. Greatly appreciate it.